Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. On the podcast today, I'm speaking to Alex Matheson from the LGBT Foundation about improving care for LGBTQ plus people. In this conversation, Alex talks about the health inequalities experienced by LGBTQ plus people, in particular around access to services and the discrimination some people experience, and how these ultimately impact on outcomes for this group of patients. She also explains the LGBT Foundation's Pride in Practice programme and how it can help GP practices to improve the experiences of LGBTQ plus people accessing primary care, as well as the importance of training for staff and recording patients' sexual orientation and gender identity. This is a really important conversation, so I hope you enjoy listening to it. We've put a link to the Pride in Practice programme, the LGBT Foundation's report on health inequalities, and the Gender Identity Toolkit for GP practices that we discuss in this conversation in the notes for this episode. I'm really pleased to be joined on the podcast now by Alex Matheson from the LGBT Foundation to talk about the charity's Pride in Practice initiative and how it can help practices to improve the experiences LGBTQ plus people have of accessing primary care services. Thank you so much for coming on the podcast, Alex.
Oh, thank you for having me, Emma. I'm really excited to talk about everything with you today.
As I mentioned there, you're the Director of Inclusion at the LGBT Foundation. Can you explain a bit about what the foundation is and the work that you do?
We're a national charity and our aims are around supporting LGBTQ plus people to be able to live happier, healthier and more fulfilled lives. We have a service delivery arm, so that includes services such as we offer talking therapies, IAPT, and we have a recovery team. We cover domestic abuse, sexual violence, for example. We also are a partner in a gender healthcare service, Indigo, which recently went from pilot to full commissioning, which was quite exciting. And then there's my side of the organisation, and that's focused on improving inclusion across all walks of life for people.
So one of the initiatives you're responsible for in your role is Pride in Practice, which aims to improve the experiences of LGBTQ plus people accessing primary care. But before we come on to talk a bit more specifically about what that programme is, I thought it was worth talking about some of the reasons why a scheme like this is necessary. Many people in the LGBTQ plus community experience health inequalities. You did a report on this issue at the end of last year. Can you explain some of the key findings from that report?
Yeah, absolutely. And I think, like you mentioned, people do experience health inequalities. Dr. Michael Brady, who is the National LGBT Advisor for the NHS, actually said that in all the areas where the question is asked, LGBTQ plus people face poorer health outcomes. So wherever we look at that difference, there is always a disparity of experience, which I think is quite telling. Within our report, we focused specifically on experiences of patients accessing primary care and specifically their GPs. And we found that quite significantly, only 56% of LGBTQ plus people felt that their GP was meeting their needs. And that actually is a number that has dropped over the past 3 years. So it was in the mid-60s a few years ago, and it's continued to decline, which isn't a huge surprise because we know that has happened for other groups as well. What we did find is that 17% of people also said that they'd actually experienced some form of discrimination from their GP practice, which, is quite a significant amount. And 58% of those who experienced it felt that they weren't able to raise their concerns. So they didn't feel that they would be heard, that the people at the practice would actually take on board what was happening. So they just disengaged, essentially. And we also found that the number of LGBTQ plus people who said they were registered with a GP has decreased over the last 3 years. That's quite significant because we know, not accessing a GP, it has such an impact on a wide variety of things. You're not included in any preventative health measures, any population health screening, for example, and it really does tell just how disengaged the community is getting. So when we looked at it, we found that the biggest disparity across the groups was for bisexual people. So only 89.5% of bisexual people were registered with a GP practice. And in terms of looking across age categories, we found that the biggest disparity was in the 25 to 34 age category. And in that group, 17% of LGBTQ plus people aren't registered with a GP at all.
If people aren't accessing services, then inevitably they're likely to be experiencing health inequalities, aren't they? So it's actually getting people in the front door at the start is so important for everything, isn't it?
Absolutely. And that lack of registration is really telling. Because if you think, we know that people are having poor experiences when they do attend, but actually you've got that significant portion that aren't even registered. So they're not even getting any communication from primary care at all.
Have you done any research about why these people are not registering with their GP practice?
This is part of our follow-up process that we're going to be looking into in a bit more detail. We've had some anecdotal evidence because within the survey that we did, there was the opportunity for free text for people to put explanations. Some of it was that people had previously moved and couldn't find a GP practice that was in their new area that they knew they could feel confident around. And we found that especially for respondents who are trans and non-binary. We hear that a lot within Pride in Practice. We get a lot of contact from individuals specifically wanting to know who in their area has done PIP so that they have an expectation that they will be supported. The other thing that we've seen is that there's higher levels of insecure housing, and that can lead to lack of registration with GPs as well.
There's a lot of evidence in particular that LGBTQ plus people often face higher rates of mental health issues than other groups in the population, including anxiety and depression. Can you explain a bit about why that is and what we know about this?
It's very nuanced and complex, as you would expect with, something around mental health, especially anxiety and depression. And there's no one key thing, but it's a combination of all the different things. But if we think about those things that contribute to poor mental health across the general population, we do see that they do disproportionately impact LGBTQ plus people. So when we're thinking about the social determinants of health, things such as housing, employment, education, and activity levels, we see across all of those that there are worsening circumstances. So we did some analysis on the census data because now we are included within the census data, so we can get an idea of the experiences from that. And when we compared LGBTQ plus people to non-LGBTQ plus people, we could see significant differences. For example, thinking about housing. So those people who are living in overcrowded or less secure housing. For lesbian, gay and bisexual people, they were 2.4 times more likely to live in either a bedsit or a shared rented accommodation. And for trans and non-binary people, they're 2.6 times more likely. And we know that poor living circumstances has an impact on mental health. When we look at employment as well, for example, trans people are 3 times more likely to have either never worked or to have been on long-term unemployment. And that ties into the fact that in one of our earlier studies, employers actually said 1 in 3 of them said that they just wouldn't consider employing a trans person.
Gosh, that's really shocking.
Both of those things, just simple facts that aren't actually health measures, see how that has an impact on mental health because you've got less income, you've got less security, your housing is unstable, you're more likely to have disproportionate amount of your income going on your base needs being met, and that has massive impact on mental health. And then you add in things like, further societal disparities, so higher levels of youth homelessness. So even for those who are older in age, they've not had as secure an early start, increased isolation. You see that across our communities. And that kind of stems on as well from things such as like rejection from families, increased risk of violent attacks and hate crimes being on the rise.
You touched on discrimination earlier around healthcare. How much of a problem is discrimination, homophobia and transphobia in healthcare in the NHS, and how does that actually impact on people's experiences of engaging with health services?
It's quite significant. And I always find it really shocking just how many people have encountered what they consider direct discrimination, like an example of homophobia or transphobia or biphobia, but also how many people have encountered those negative scenarios that they wouldn't necessarily go, oh, I was being discriminated against, but it made me feel uncomfortable. But when we look at direct discrimination, almost a quarter, 23% of LGBTQ plus people have encountered that within health services based on either their sexual orientation or their gender identity. And actually, when you unpick it and you look at the NHS staff survey results, which we do, it's not just patients. This is happening disproportionately at higher rates for staff as well. So if staff are encountering it, then of course patients are encountering it. That impact is really significant. And it does lead to disengagement and lack of access. But it's not just those like really significant big ticket, like this was an awful incident that happened, I heard someone saying this or told this. It's also just the general behaviours and attitudes that people are exposed to, and also like the structural inequalities. So, you know, for trans and non-binary people, the significant wait time that they have to access gender-related healthcare, or things like the misinformation that's being given to people because of their identity. I'm always really stunned, and this is a statistic I share quite regularly, because although I had the experience myself, I didn't realise that it was so widespread. I thought it was just a weird me thing, but almost a third of lesbian and bisexual women have been told at some point by a healthcare professional that they don't need to engage with cervical screening because of the sexual orientation and, you know, who they're actually sleeping with. And it's that misinformation and lack of understanding and nuance that really leads to those poor outcomes.
And if they have really poor experiences, they will talk to their friends as well. So ultimately that probably leads to other people just not even bothering even going somewhere because they just feel like they're going to experience some unpleasant behaviour or hear some comments that they just don't want to hear.
Absolutely. Obviously, I work within an LGBTQ organisation, so we all talk, but also like my friends talk. But there's loads of online forums and ways in which the community connects as well, and they do it both ways. You know, we see so many different opportunities for people to share where they've had good practice. And that happens a lot, especially for trans and non-binary people, where, you know, they'll share, actually, this practice has been really wonderful. Or, you know, they'll share where they've gone to get perhaps a trans masculine person or a non-binary person's had a cervical screening and been treated really well, and they'll share that.
You've touched on it a little bit, but is there any differences between the experiences of LGBT people and trans people? There's such toxic discussions around trans issues in recent years. Has that impacted on the experience that trans people have and non-binary people have within the NHS?
It's had such an impact in terms of their actual direct experiences. You know, if you think about what happened in, say, the last 12 months of the prior government, they put out a huge amount of consultations and guidelines that related directly to trans people and specifically in healthcare, a lot of them. And many of them weren't finalised or passed, but the information and the guidelines being out there created a sense of fear. For the community members themselves, so I'm thinking about the proposed updates to the NHS constitution around single-sex spaces, for example, people feeling like they won't be able to be placed in the appropriate gendered ward for them, and that leads to them disengaging and them just avoiding going in because they're scared about what will happen. And more often than not, it's not that they're scared of being put on the wrong bay, it's that they're scared of what will happen to them if they are. You know, they are scared of being physically attacked. They are scared of being put in a very vulnerable position. And then conversely, we've had a huge amount of inquiries from healthcare practitioners across primary and secondary care who are concerned about the impact of these consultations and guidelines because they see that in their area of practice, they're starting to be implemented, even though they're not yet in place. And people are starting to change their way of working. And people are like, I don't know what the right thing to do is. And that's all around trans identities. And we also, as I said, I mentioned some of the other stuff, the structural barriers that exist for them in terms of like accessing gender-related healthcare and the lengthy waits. And if you think about like the process for a gender marker change within the NHS, that in itself is, a real structural barrier for a lot of people and leads to poorer experiences. Things like no longer being included on call recall systems for those population health screening that they should be getting. So there's lots and lots of different areas in which that toxicity has a real life effect, not to mention just the draining ongoing onslaught of seeing your identity vilified consistently in the media.
When you look at all of this, the experiences LGBTQ plus people have of accessing services and discrimination, what does all of it end up meaning in terms of health outcomes for people? Do we have any data about that shows the impact of all of this?
Yeah, we see consistently that LGBTQ plus people have, significantly worse health outcomes. Just what I've shared already, you can understand exactly why. If you're not accessing a GP or you've not got a good experience of healthcare or a good relationship with your own GP or the practice, you're not accessing screening, all of this leads to later presentation with an episode of poor health. So you're more likely to be at a more advanced stage with any health condition, be it physical or mental. And then you combine in the stuff around also, you're more likely to receive misinformation, such as, I said before, the screening example, and many other examples that we see. We've had people who are HIV positive, who are on treatment and have an undetectable level, being told that they can't work with food, for example. And that was in last year's one. We had a gay man who'd been told that having received treatment for prostate cancer, his sex life was now over and that he should not engage in sexual activity as a gay man. You can see that misinformation and the impact that it has. It has an actual cost implication as well. Because if you think about when somebody's presenting to healthcare, when they're attending with a condition, if they're intending later on, they're far more likely to not be able to use a first-line treatment effectively and to need the next step up. And that's going to have, a cost implication. They're more likely skipping primary care, not being registered, not having a GP. They're more likely to have an A&E attendance because it gets to that point and we know how much more costly that is.
One of the things that you're trying to do to help address some of these issues that we've been talking about is the Pride in Practice programme. So can you explain a little bit about what that programme is and how it came into being?
Yeah, so it's been running for over a decade now. It is a scheme that aims to support primary care practitioners to improve their inclusion for LGBTQ plus people with the intent of improving outcomes. It is a scheme that includes training. So we go out and we do training with the practice staff, require that to be about 80% minimum of the staff undergo the training. We do an assessment, which allows us to get a really good understanding of where the practice is at the present stage and what they're doing good, that they can build on, areas that they need to improve. And then we create an action plan with them. And through the use of that action plan, we take them through an award. So we have an initial stage, then we have bronze, silver and gold awards. And the aim is to get practices to that gold level. And some practices that come in, they start at initial and they work methodically through the process. And then we see some practices that come in and they're like really fired up. And their next assessment, they're like straight from bronze to gold because they've just been like, no, we're doing this, and it's fantastic. It's really wonderful to see that kind of impact that it has. And then they have an account manager that can support them, so they'll provide ongoing advice. And a lot of what we do in areas where Pride in Practice has been embedded for longer time periods. So in Manchester, where we do it as a full area coverage, so it's funded for all 10 boroughs of Greater Manchester, we end up doing a lot of case holding and almost like mediation. So we'll have patients contacting us where they've had a concern or they've had an issue in practice, and we'll get involved and we'll support them. We'll speak to the practice and we'll help that get resolved without it becoming a formal complaint. But it'll also give the practice the opportunity to actually resolve it. So it's not just like, oh, they've signed off a complaint and the patient's still unhappy. It feels like they've got a resolution and they can take it as a learning opportunity. But we also do it the opposite way round, where we'll get, sometimes it'll be admin staff, sometimes it'll be the actual healthcare practitioners themselves, GPs and nurses, contacting us and going, okay, so I've done Pride in Practice, but now I've had this and I've got this patient who's come to me and they're wanting us to support with their transition, for example. That's often the one that we get. Like, what can I do? How do I do it? Talk me through. Any practice that's involved in the programme gets that ongoing support.
You said that you come in and do training with staff. So this is inclusion training, isn't it? And what does that training involve, and why would you recommend practices engage with training like that?
Yeah, so we often do it in their admin time or their training time, their monthly MDTs, for example, and we'll do it for clinicians and administrative staff. We cover a lot around the why that there are barriers. So we've talked today about those barriers, but there's lots and lots of issues that led to them in the past, and understanding that's really important. So we talk through how it came to be. We talk about the impact of legislation on LGBTQ plus people's experiences. And then we do some real kind of like practical stuff as part of that training, which is, what's the current stance around changing gender markers? How do you do that for admin staff? Details of, no, you don't need to ask for a gender recognition certificate, for example, helping them have that like real understanding of the process. We give them confidence in the language that they use, so they get talked through that big question around pronouns. How do we use it? And actually we simplify that for them and help them understand that it's not so like scary a thing, and talk them through how they can make changes to their practice to be more inclusive visibly, so they can start to build trust. So beyond that performative allyship, so people can start to see, actually, I'm safe here and I can have open conversations. I deliver training myself. One of the things that we do with Pride in Practice is we have a Play Your LGBTQ Dates Right quiz, and we take people through like different pieces of legislation and things related to healthcare at different times that have had an impact, to give that understanding of why people might, for example, feel anxious about going to the doctors, even if they haven't personally had a poor experience. And I was doing some yesterday and I was talking through like in relation to my life. So I'm like 44-year-old queer woman. And when I was one, it was when I was one was the last recorded incidence of aversion therapy being offered on the NHS as a cure for homosexuality. I say I'm old all the time, but I'm really not that old, right? I'm middle-aged. But during my lifetime, and like smack bang in the middle of my mum's lifetime as an adult, and we've still got conversion therapy going on, and that's not been banned yet. And that's before you get to the discussion around like including trans people in protecting them from conversion therapy.
Do you know how many practices you've got who've taken part in the programme so far?
We're just over 1,000 that are active at the moment. Most do remain engaged on some level. They might not renew every year because they're working on stuff. What we often find is like in an area, especially in like a PCN, they'll have so many do 1 year and then so many the next, and then they'll come back to the original group for reassessment. When a practice signs up to do Pride in Practice, they get 12 months support package. So dependent on how it goes for them and the amount of change that they need to implement, there's every possibility that they could start and get gold within that time. Or within the 12 months, they might still be working. And those that get gold, we recommend get reassessed every 2 to 3 years.
Doing a programme like this and being able to stick the We're a Pride in Practice thing up, that is obviously a really easy way of doing it. But is there other things that practices can do to make sure that their patients understand that they are a welcoming place for LGBTQ plus people?
It's always important to have some form of visible inclusion. It's that thing where you walk into a practice, how do I know that they understand my needs? How do I know they've even thought that I might have different needs? We see in the training that we provide so often, people will say, well, it doesn't matter who you sleep with. Why would it change the care you get? But it does, as we know. So actually seeing something, having details of an LGBTQ specific service, like we have posters and resources that we provide because we've got our helpline, just something as simple as that, for example, gives people an indicator, oh, I've been thought of. But then also things like, having inclusive patient registration forms. Do you ask for sexual orientation monitoring and trans status? So at that point, when someone's registering as a new patient, they go, oh, yeah, I can put this down, I can be seen, and I can have an expectation that my care will be appropriately informed by that information. And they're like just two really quick, simple changes that make such an impact.
That seems to be really important in one of the things you do about recording patients' sexual orientation. Why is it so important? Is it just for that, or is it important for wider healthcare reasons?
Firstly, we have a saying, and it's all over a lot of the work we do with Pride in Practice, which is if we're not counted, we don't count. And that's so true in healthcare. If you don't know who your patient cohort is, you can't have an understanding of their needs. And we see that demographic monitoring has had such an impactful change in healthcare over the years for other groups. If we think about COVID, we saw that there was a disproportionate impact on certain ethnic groups. We wouldn't have known that if we weren't monitoring ethnicity. And it's exactly the same thing. And in fact, when we asked patients in our survey, 70% of patients whose GP asked their sexual orientation said that their needs were being met by the practice. That shows the impact like so significantly. But interestingly, so I worked on the NHS Rainbow Badge project and we did a staff survey on that. And we asked over 19,000 NHS staff information relating to LGBTQ plus awareness. And across the board, those who were patient facing said that they believed that it was important to be able to deliver best quality care to know someone's sexual orientation or their trans status, which makes perfect sense to me. But it's really great to have those percentages to be able to go, okay, 75% of clinicians say that they believe that is a key factor for your sexual orientation. And actually, it's higher. It's in the mid 80s for people believing it's necessary for trans status.
When you actually go into a practice and you're trying to help them, what are some of the key things that practices tend to have to work on? What are the most common things that you find that practices have to improve?
Always, pretty much, they have to start off some form of sexual orientation and trans status monitoring. It's quite unusual for us to go in and them already be doing that. So that's always like a key thing. But I think the key change is like the understanding and the learning that they need to go to and then actually applying that. It's quite interesting. So we do a bit of like a knowledge check as part of the assessment, and that's where a lot of it starts to unpick. And that's where it's the difference between what the practice needs to do and what the individuals need to do within the practice. I mentioned it before. The most common thing that gets said to me when I'm doing either training or I'm going and doing a talk, the most common thing I get is, it doesn't matter who you sleep with. I'm going to give everyone the same quality care. Okay, that's not personalised or holistic care for a start, but we'll park that. If you're giving everyone the same quality care, you're ignoring what's led to them getting to see you. You're ignoring the 17% that aren't seeing you because they're not registered. You're ignoring the poor experiences they've had previously, the misinformation. And unless you know that, you can't address that. Going back to the example about the lesbian and bi women that have been given that incorrect information about a smear, if you know that and you've got a patient and you're doing sexual orientation monitoring, and so you know that patient falls within a lesbian or bisexual woman, and you're seeing them and you see that they've DNA'd on their smear tests for the past, however many, you might have a bit of an understanding then to next time you see them say, by the way, I'm just checking, you do know you still need to have your smear. I know obviously your partner's a woman, but just making sure you're aware. Do you have any concerns around attending for a smear? And it totally changes it. It's become a considerate, caring, sensitive discussion with someone who recognises that there could be a barrier there.
I know that the LGBT Foundation have been involved in developing a gender identity toolkit for practices that helps practices put in place processes for dealing with patients who are changing their gender in their records. And you kind of touched a little bit on that earlier. So what's important for GPs and practice teams to bear in mind when they do have patients who come to the practice to request a gender change on their record?
Firstly, just remember that this is such a big deal for somebody. there is an anticipation. We see it in the communities that people are going, and so this is a big thing. I'm going to go and request this change, and there's a little bit of fear. Am I going to get knocked back? Is it going to be done? Are they going to question me? What's it going to be like? So your approach, just being friendly and personable, can have such an impact on such a significant activity within their transition. So being sensitive, being considerate, being kind will make a difference, and it will absolutely impact how they view the practice going forward. But thinking more about the practicalities, so some practices will require that patients have an appointment with either a nurse or a GP so they can talk them through the implications of getting a new NHS number, because a lot of people might not realise that it's not just changing their gender marker on their current file, that they'll get an entirely new NHS number generated, which is essentially a completely new NHS record, and the implications around that. So some practices will say, oh, you have to have an appointment with a professional, which is fine. So, making sure that that's booked in and the patient understands that it's not to gatekeep, it's not to stop them doing it, it's to talk them through what they need to know. But places where they don't do that is also equally fine. But I always recommend that they offer to have that conversation with someone in private. So, oh yeah, great, we can sort that for you. Let's just go off, we'll find a room and I can talk you through the process. So you're not having that conversation in that public space where you've got 3 people waiting behind you and they're shuffling and mumbling and they're getting fed up because you're taking a while, and giving people that privacy to be able to just talk them through the implications that it'll have for them will be really, really useful.
Based on all of this that we've been talking about today, what key bits of advice would you give to GP practices as a whole about how they can improve the care they provide for LGBTQ plus patients?
Know who they are, know that you've got them.
Yeah.
First of all, if you don't know who they are, you don't understand the barriers that they've experienced and you can't support them with that. So do that monitoring and really pay attention to the outcomes. Absolutely engage with some effective staff education so you have that knowledge and you can back it up. So, creating a visible, inclusive environment is the first step and is really important, as I've said. But if then they experience poor care or they're treated badly, that means nothing. So making sure that you have that understanding, you've had that education alongside so that you can give that good quality care is really important. And taking the time to actually understand why it matters. Because the impact on somebody knowing your identity and using it properly is so significant. I have a great relationship with my GP. They have done Pride in Practice. They are a gold. And one of the simplest things they do that makes me feel safe is when I go for an appointment, I've got a long-term condition, so I see my GP fairly regularly. They'll always ask at some point, how's your wife doing? They don't say partner. They don't hedge the bets because they know I've got a wife. It puts me at ease. It's such a simple thing. And I contrast that with last year when I had to go to A&E and the experience that I had there where somebody, seeing that I was Mrs., they asked me about, is your husband coming tonight? And then you're in that situation of, well, firstly, no, I haven't got a husband, but now I don't know if I'm safe to tell you that I've got a wife because you've made an assumption. If I correct you, are you going to then treat me differently? But if I don't correct you, then I'm denying my wife. And that doesn't feel right either. So what should have been like a 30-second interaction has become a real source of discomfort. It's just such a simple change in language there. So it's just remembering the impact that knowing your patients and treating them personally can have.
Thank you so much, Alex. I've been really, really enjoyed talking to you today. Thank you.
Oh, thank you, Emma. It's been fantastic. Thanks for having me on.
Well, that's it for this week. Thanks so much for listening, and thanks to Alex for speaking with me. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.